What if I told you that you or your loved one could reverse your type 2 diabetes with diet and manage your type 1 diabetes with diet? Well, I'm here today with a doctor that's doing just that, Dr. Rohn Rigby from the Utah Medical Center in Ogden, the Ogden Clinic.
Ogden Clinic, yep.
And he is a board-certified MD in obesity, especially. And I'm excited that we got to connect because I went through my own weight loss journey last year using keto, low-carb diet that I've kind of transitioned to carnivore. And when I went on the Diet Doctor website and saw you listed, I made an appointment as quick as I could. I'm like, finally, maybe I'll find a doctor that understands what I'm talking about. So I'm glad to have you on the show.
Well, thank you.
Great. So I want to start with, 8 out of 10, 9 out of 10 people, Americans in this country have some form of metabolic disease.
Yes.
So will you briefly describe what that means? What is metabolic disease?
Well, metabolic disease is looking at the metabolic programs or processes inside our body. So physiological type issues. So a lot of times we'll talk about metabolic syndrome, which will have an elevated blood sugar or a large waist circumference or high blood pressure or have cholesterol issues. And unfortunately with the cholesterol, we always talk about total cholesterol, but even when we're looking at metabolic syndrome, they don't even include that. We look at more of the HDL, quote unquote, the good cholesterol, and there's no good or bad. We just make it simple that way, but the one you want higher is your HDL or your good cholesterol and your triglycerides or extra fat floating around your bloodstream. So it's looking at some of those different aspects, but even thyroid issues, high blood pressure issues, women who have irregular menstrual cycles or have a syndrome called PCOS or polycystic ovarian syndrome, where they have multiple cysts. Again, you don't even have to have cysts on your ovaries to actually have problems with it, but all kind of correlates back with the hormone insulin and having insulin resistance.
Yeah, and I've done a lot of studying on insulin resistance. Dr. Jason Fung's work is usually the top of that list. So, I've kind of gone from being very insulin resistant, almost pre-diabetic last year, to losing 60 pounds and being
which is great.
Very
keep it up.
Yeah, thanks. Very insulin sensitive now, and I've even got to the point where this last month I've been using a CGM just to see what kind of foods really affect my blood sugar, and I think it looked really good recently. So, define insulin resistance real quick for us.
So there's multiple different discussions on what insulin resistance is. Basically, the cell and the insulin. So insulin's a hormone that's released from the pancreas that helps regulate lots of different things in your body, but a lot of times helps, the main one we know of, getting sugar into the cell so we can actually use the sugar as energy. Can help it get into the mitochondria, which is kind of the the energy molecule inside the cells, so we can actually do a lot of the different functions. So it can definitely help. So it's helping a lot of different aspects. But insulin resistance, some would look like the insulin and the cell communication doesn't work very well, so your body has to make more insulin. Others would argue that the cells become so full of fuel and energy, or fat basically, that they produce less receptors or keys that lock. So we're trying to put more into the cell. They make less, so they won't allow more into the cell. So there's arguments back and forth on really what it is, but it's basically your cells and the insulin doesn't respond as well. Therefore, your body compensates and makes more and more insulin, causing hyperinsulinemia. So hyperinsulinemia, or high insulin levels, and insulin resistant, a lot of times we throw it back and forth, but it's actually two different problems.
Yeah, and I've heard it described as kind of, if you've ever been to Japan or at least seen videos, you've got all these subways, the trains in Japan, and people are just lined up and they're packed in there, right? And when you're insulin, resistant, you've got these people shoving more people into the trains, right? You're trying to store this sugar into your cells. Yeah. And you need more insulin, more and more to do that. And
that's kind of this common thought process, is that it's those pushers or insulin pushing the people into the subway cars. The other analogy, kind of the same idea, is you have pushers, but you have less cars. we have to push the same number of people in. So
Gotcha.
it's kind of that combination of still trying to get people off the deck from a variety of different ways. Either you hire more pushers or you just have less trains to get that same number of people on. So it's that debate and arguments back and forth. But again, in a way, it's still the same problem that you have a lot of sugar floating around your bloodstream that can now cause problems. And keep in mind that insulin, either produced by your body or for the type 1 and type 2 diabetics that we're treating with insulin, insulin is a growth hormone, causing cells to grow and get bigger.
So how does insulin play a role in fat storage and blood sugar?
Well, like we were talking about, it's shoving more fuel into the cell. And a lot of times it's more of the sugar or glucose into the cells. And every cell has receptors for insulin. And that's where insulin resistance or the problem with insulin affects every system of our body, from our brain to your toes, the nerves, the vascular system, the heart, the lungs, the liver, the pancreas, the spleen, all the different organs and your ovaries and the reproductive aspect. It affects everything. So that's the difficult part is you're going, I'll just worry about this. I just have one symptoms. We're presenting with a lot of different type of issues. You can have the same problem. You can have family members of 5 or 6 people with the same problem present in 5 or 6 different ways.
And why do you think that this insulin resistance and obesity crisis has really skyrocketed over the last 30 years?
Well, there's multiple different factors, but probably the biggest one that has the biggest effect would be the dietary changes that were incorporated by the government in late 1977 by the McGovern report saying we need to change our lifestyle and eat more carbohydrates. And again, they weren't intentionally trying to hurt us. They were trying to solve 3 problems. We thought that having more fat in your diet actually caused heart disease. So we figured if we cut out the fat, that'll help with that underlying problem. We also had malnutrition. So we were trying to feed more people. And then people were having starvation issues. So the idea the government stepped in and said, we're going to make it as feasible as we can to feed more people. And unfortunately, they started subsidizing some of the different systems out there where they subsidize the grains, the corn, the soybean. Yeah. And when we had excess, we had to go, well, we're paying for it. We got to do something with it. So we now incorporate in other things. And so again, they had a good intent behind it. It was kind of a big experiment 40 or 50 years ago. They didn't know what the results would be. We just said we're supposed to do this. And now over time, our bodies have adjusted to having some of those problems. And that's where looking at our genetic makeup, looking at family history. Oh, grandma, grandpa, mom, dad, aunts, uncles have some of these problems. That puts that person at higher risk.
At higher risk, okay. And what about the low fat, the 80s, the low fat craze, or, like you were saying, the government guidelines kind of push that.
Yeah.
They push down, don't eat butter, don't eat lard, that type of thing. Eat the vegetable oils, eat the margarine. Mm-hmm. How has that impacted some of this insulin resistance?
Well, it's a huge part because of the idea of lowering the fat. Well, we only have what we call macronutrients. We got proteins, sugar, and fat. So if we're taking away one and we've been taught to avoid the other, that only leaves one other thing. So it's kind of, we can only mix and match those 3 different things. And unfortunately, when we're talking macronutrients and stuff like that, it's what the scientists are looking at. Unfortunately, we're actually looking at food, and it's how those foods affect those ratios. So that's part of it. But when we're told people to take away one of them and the government subsidizes the other, it's like, well, let's add a lot more of these certain things. Now, again, intentionally, they weren't trying to cause any problems, but then the manufacturers got in the way. Right. And again, they're not intentionally trying to hurt. They're trying to make money. They're right. trying to sell things. So if I'm a CEO of a manufacturer company or a food company, my goal is to make money, to keep my CEO, keep my stockholders happy. So therefore, I'm making things that make us money so I can keep my job. So they're not intentionally trying to hurt people. They're intentionally trying to make money.
Right. Yeah, and they're just using those subsidies, right? Those mm-hmm. subsidies on grains and the cheap vegetable oils are a lot cheaper than like a coconut oil
exactly.
or an avocado oil or, olive oil or something like that.
And that's the thing we don't always get into is they say, saturated fats are dangerous. Well, we're now learning that trans fats were bad. Well, why are we having trans fats? We're taking these hydrogenated fats and we're now altering it to make it work similar to a saturated fat, because to help with baking and cooking and that type of stuff. Now we're finding out that's a bad thing. Mm-hmm. So now we're trying to shift over to other types of fats that potentially could be worse. We don't know.
Yeah. I think, in my journey that I've gone through, this weight loss and health journey, I always go back to the same thing, and it's the ancestral diet, right? Mm-hmm. It's what my great-great-grandmother or even great-grandfather or even grandfather grew up with, right?
Exactly.
They had this whole fresh raw milk that came to their door, right? They went out and, they were on a farm and they were eating, fresh produce that didn't have, insecticides and pesticides in that time.
Yes, in season. That's part of it. Like exactly. Right now, we're in late May and really seasons are starting to grow, but there's nothing really growing. You're not going to be able to go out to my garden and go, oh, I'm going to have my watermelon, or I'm going to go grab an apple off the tree, or I'm going to go have some grapes, because they're not in season right now. Right. Yes, you can get some spinach or some chard that you started earlier when it was colder. Now it's starting to grow a little bit, but you couldn't go out and run to the grocery store and go grab all these things. You ate it when it was in season.
Right, and we didn't have refrigeration, not too long ago, right? So we weren't eating these things all year round. We didn't have the transportation to bring them up from, South America, Central America, all these bananas and tropical fruits.
And again, we don't have the genetics to be in those environments. And some people who live near the equator, were exposed to it on a regular basis, did well with it. They do a lot better. But unfortunately now we add the processed sugars on top of it. That makes the issue. So it's not always, unfortunately, we try to make it simple. It's just about carbs and carbs. It's not always just carbs. It's the processing of the carbs and the processing of the oils that are the worst part. But some of us who are more sick, we have to get more aggressive. And going back to the diabetes versus an insulin resistant, insulin resistance kind of a part way. You have to treat it some way or aggressive. But if you're more sick, we have to go more aggressive.
Right. So let's go back to the vegetable oils a little bit, because I think a lot of people, including myself, I didn't realize how harmful these hydrogenated I can't say that word, but hydrogenated vegetable oils are, and really the manufacturing that goes into expressing these, pushing these seeds down both manually and with chemicals, and how that really affects our bodies. Can you talk about that a little bit?
Well, yeah, because they're all process type things. So they're having to go through all these different processes to make a substance. And actually, most of the substances originally were for lubricants, were for soaps.
Yeah, for like metal, right?
Exactly, for
like
all these
oil.
different components.
Actual oil.
And when they had an excess, they started doing different tests and saying, well, maybe we can actually do something else with it. And they made it into food-like products. So therefore, we started to have it. And again, when you're getting a small amount, it's still dangerous, but it doesn't affect us as much. But now we're getting larger amounts on a regular basis, can play a bigger role.
Yeah, you go to the grocery store and you look at these packages of packaged foods, snacks, cereals, whatever, and almost all of them have some form of vegetable oil. It's hard not to find one.
Yeah.
You have to go to the special section. Like I looked at some chips recently, and then there's a small section that's made with like avocado oil or coconut oil.
And again, it's also more expensive because those oils haven't been processed and we're not coming from other products. Therefore, and again, unfortunately, society is going, oh, the vegetable oils are good. And unfortunately, there are no vegetables in those oils. They're all coming from seeds and grains.
Yeah,
exactly.
Seed oils, right. So let's go back to the processed sugars as well, because I think that's a big part of why this obesity crisis has kind of gone, because we have 7-Elevens, convenience stores on every corner, right? We've got these fast food places that sell these sodas for cheap. What do you think that has done to just our physiology in general and our health in general?
Just the sugar aspect?
Just the sugar, and I think even more so, just how accepted sugar is in our society, right? And it's like, oh, that's no big deal. You can have a soda, you can have a candy bar, whatever.
Well, if you go back in history, and there's multiple books out there looking at the progression and how the amount of sugars that we had way back in the colonial time. And I'm not a big evolutionary person, way back in caveman type of thing, But just looking back in just the United States history, which isn't that long in comparison, we weren't eating that much sugar. Now we're consuming tons upon tons, and it's in processed food. We put it in everything. And when we're having the sodas that have all that sugar, we're just drinking it, and not having the solid food with it doesn't affect our body the same way, and we don't get the signaling to tell us that we're full, so we can eat more and more and more. And a lot of people go, it's all about calories. And technically, our body doesn't even understand what a calorie is. It's a man-made interpretation of a unit of energy. So your body doesn't know what a calorie is. So when we're putting all these different components in, that we're bypassing some of the physiological process that we have in our body, kind of sabotages some of it.
Yeah, and you can go back to an evolution, but even now, obviously we crave sweet things, right? And it's because those things used to provide a lot of calories for us in times of need, right? So if the vegetables weren't around, right, we would find some honey or find some fruit that was out there, and we'd eat it because it's got good calories, right?
Exactly. You wouldn't have as much, but it was a treat in its season, and that's part of it. At least I always go back to the idea is, if it's in season, great, have it, but I always look at treats or fruit as nature's candy.
Right.
So you can have it when it's in the season, but after you've had the essential things, where your essential amino acids, your essential fatty acids coming from proteins and fats, having the micronutrients, the salts and minerals. And if you still need something, that's where fruit comes in, or that natural sugar. But again, we've hybrided basically and made these bigger, sweeter types of things, because that's what people want. And again,
it's the market.
The market, and that's what people want, is we want more sweeter type things. And unfortunately, and studies have shown, and there's arguments and people it doesn't show as much, but studies have shown in mice, and yes, we're not lab mice, but in lab mice that sugar is more addictive than cocaine. And that they will bypass these addictive substances to get sugar, and how the rewards they get with that sugar. And unfortunately, because of that, that's why manufactured products will have a lot more sugar in, because the manufacturers are trying to find that bliss point where a majority of people will actually buy it and eat it at a certain level. If they go too much, it's too much, and a certain percentage won't eat it. If we don't go enough, not enough people will buy it. So they find that quote-unquote bliss point, and adding sugar and some of these salt and other fats, more of the vegetable oils, to kind of hit those levels.
Yeah, one thing that I learned was that these big food companies hire a lot of, scientists, right? A lot of chemists, nutrition people, scientists that really know how to mix the fats and the sugars and the salts, like you said, into the perfect, chip or whatever it is, so that you keep coming back and eating more, right? And they keep selling it. And like you said, it's profit, right?
Yeah, and that's why I always call it food-like products, because it's not technically natural food. It's been manufactured. It's been concocted, and a lot of the research will show that they come up with what they want, the end product, and reproduce it to go find the products that will actually get what they want, have the right combination. So they're creating these products.
Yeah, they're
in a
lab, right?
Exactly. There are, like you said, there are a lot of high-level researchers that's what they do, but they also take a lot of time and money and put people into functional MRIs, which is actually looking at how your brain, different areas of your brain, how they light up with different things. They have the same, somebody who's addicted to sugar has the same effects in the brain in those functional MRIs to people who are addicted or getting their drug of choice.
Yeah, and I think that was a critical point in my journey was, instead of denying it, just accepting that, okay, maybe I am addicted to sugar. And I think a lot of people out there would deny it, right? They would say, oh, I'm not addicted to sugar. And then they look at if you keep a food log, right, or a food diary, you look at everything you eat, and there's a lot of things with sugar, right? There's like spaghetti sauce has sugar, pizza sauce has sugar, ketchup has sugar. You've got these fruit juices, right? So talk a little bit about fruit juice. I used to think that was healthy, right? Have some apple juice, have some orange juice in the morning, have some apple juice. Talk a little bit about that.
Well, we've always been taught that you're supposed to have that, and it's been marketing to say we're supposed to have those things for a particular meal. And yes, they would put fruit juice, but they also put other type of sweeteners in it to make it sweeter. It's sweeter than the actual fruit. But part of it is we don't have the fiber. So if you were going to, let's use pick apple juice. So let's say you would have a glass 8 ounce. So that's the equivalent of probably 10, 11, maybe 12 apples.
Wow. Yeah. Who's going to eat that many?
You're not going to sit down and eat 12 apples at once. You might eat one, maybe 2 at the most, and you're going, I'm done. The fiber bulks it up. You get the signal that you're full or you can't eat anymore, so you stop. When we've now broken or taken the sugar away from the fiber, we don't get the stretch receptors in our gut telling us that we're done. Therefore, we can drink a lot more and more and more. Now, another effect is that, excuse me, that with higher levels of insulin can block another hormone called leptin that's released from the adipose or fatty tissue to tell our brain we're full. So when high insulins can block that, so therefore your body has to make more and more and more signals to say, come on, guys, or come on, brain, will you stop feeding us? We're stuffed. And a lot of times looking at those levels can give us an idea of that, getting back to that insulin resistance. But that's a lab test you have to go look at.
So let's dive into a little bit about your practice and your patients.
Okay.
So tell us a little bit about what kind of patient typically comes to your office. Is it someone just wants to lose weight? Is it diabetic? Both?
Both. And unfortunately, well, I'm not saying unfortunately, because I focus on obesity medicine, and that's what the ABOM, after my name is, American Board of Obesity Medicine. I got into it because I struggle with obesity, and I was wanting to try to solve the problem. And it's not always, unfortunately, we start with, we'll just add medicines to kind of make it so you're not hungry. Our body can outdo that. We can out-eat those things. But when we start incorporating diet is when you start affecting the metabolic health. So a lot of times when I started this whole process, I wanted to call it metabolic health. And my advisors were going, we understand what it is. The layperson out there who doesn't know, it's not going to have a clue when we call it metabolic health. So we call it medical weight loss, because everybody always wants to, no matter how big or small you are, we always want to lose weight.
Yeah.
So we focus on the weight, and it gets frustrating at times when you're trying to lose weight and you're not seeing it, but a lot of times you're fixing that metabolic health at first. So trying to take it internally, so trying to fix that metabolic health. So the patients I get a lot of times referrals from some of the specialists like orthopedic surgeons who, you need a total knee. Well, your BMI is 40, your insurance won't let us do it till it's 35, so go see Dr. Rigby, let's get your weight down so we can do that study. Gotcha. Or do your test, or get that surgery done, or you have back surgery, well, let's do that. Or your diabetes is really out of whack, well, we can go on more medicines. I don't know, most doctors going, I don't know what else to do. We've tried multiple different medicines. Maybe go see Dr. Rigby, maybe he can help. Or you got thyroid-related issues, or you're sick and tired of going to your doctor and going, all you do is keep giving me more medicine. Again, nothing against them, because they're doing what they think is exactly what we're taught. Yeah. We're not taught, well, a couple of things. We're not taught how to do or teach nutrition. In fact, most of mine came from undergrad. I went to Weber State, and part of my bachelor's was in nutrition, but what I get taught, the standard American diet. And again, I thought that's the way it was, and obviously it didn't work for me, and we can get into that down the road. But is looking at it from a different perspective. So they're not intentionally trying to hurt you. They're trying to do the best they can by using their tools that they know how to use.
The standard of care.
The standard of care. Unfortunately, the standard of care doesn't always work in every situation. So I get patients from the weight loss, want to lose it, or maybe a female who's having a hard time getting pregnant or wants to get pregnant, and their OB has said, you got to get your weight down or it's going to be harder to get pregnant. So I'll get patients from that.
So what's the first thing, if someone came into your clinic, what would be like an initial visit look like? And what's the first thing that you try to tackle?
So I know it's a lot of work, but we send out basically 6 pages of looking for information, looking at past medical problems, looking at the medications. When did they start gaining weight? How much were they when they were born? What are the family history? Where's mom and dad at? Looking at all these different aspects. What have you tried in the past that's helped? What didn't help? And trying to approach it from looking at all those different factors. And I'm looking for different risk factors about that insulin resistance. And I admit it up front, I'm looking for factors of it. And after we talk about it, then I talk about nutrition aspect? Do we use medications, pros, cons of all those different things? Prior to me talking to them, a lot of times we'll put them on a bioimpedance scale. So it's a fancier scale that sends low voltage, easy for me to
electricity.
say, low voltage electricity. We will help each other
Yeah,
there.
there we go.
And it sends low voltage electricity through, and it kind of figures out what's making up your weight. Because unfortunately, we get so wrapped up in the number on the scale.
Mm-hmm.
Well, it could be muscle, and it's great, or it could be nothing but straight fat. And where's the fat? If it's a female that's got more hip and leg weight, it's not as bad as having the visceral fat or fat around the organs. So this gives us a better idea of where that fat's located. And then a lot of times I'll try to do an indirect calorimetry test where it'll give us an idea of what's your metabolism. Because again, you could have a fast metabolism and you're burning energy effectively. But if you have that, but have the risk factors of insulin resistance, it's more of getting the fuel into the cell is your biggest issue, not how your cells are using it. So I look at all that, and then we have the discussion about medications. And again, I always tell people it's a journey. You didn't gain weight overnight. We're not going to lose it overnight.
Right,
We've got to figure out what's going to work for them. And then looking at different aspects. Again, we're talking about diet is a huge factor. Exercise plays a role. Stress levels play a role. Sleep habits play a role. Other medications that other doctors have put you on can play a role. So looking at all of that, I look at all of that and try to make a plan, but I'm trying to make a plan particular for that patient, not, everybody comes here, you get this, you have to do this, you have to be on this meal replacement. It's like, they can help in some ways, but it doesn't help everybody.
So trying to tailor that to the patient.
Yes.
That's great. I really appreciate that because, like you said, I think doctors have, meaningful intent that they're trying to help people, but they're seeing so many patients that they just, they say, okay, well, you got these symptoms, yep, give you this pill, right? They're following the standard of care that they've been taught in medical school, and, I'm not trying to put the blame on them, but things have we've had a lot of research and studies and new things come out since then, and since they've gone to medical school, and even while they're going to medical school that they've been taught incorrectly. So
exactly, and part of it is there's so much coming out on a regular basis, and we're learning more. The joke is when you get out of medical school, half the stuff you've learned isn't correct. You don't know which half it is. But that's the problem is you have to be, and again, there's so many things. I'm guilty of it too. If you get into problems that I could really care less, I'm not going to do a lot of research on it. I'm doing what I was taught. It's like, this is the medication. Here, let's do this. Or it's outside my realm. Let's send you to the specialist. So I'm as guilty as any other doctor when it gets into areas that I'm not comfortable, or at least I am not as trained in. But when you get into something that I'm more interested in, it's like, okay, maybe we've always been taught to do this, but is that working? Is it working for me? Is it working for somebody else? If that's not working, what are some other options? Again, the human body is a very complex system. It's not easy going, everybody's the exact same. And not every medication works the same. So that's the difficult part.
Yeah, and we're a system of systems, right? We've had a lot of different guests on, a lot of different doctors that talk about this, and it keeps going back to this theme, this holistic theme, right? You can't just look at, you've got something going on with your foot. Well, maybe that has to do with your brain. Maybe your gut microbiome has to do with what your weight loss or your weight gain. So I love this holistic approach. It's great.
Even from a traditional taught doctor. So.
Yeah, great. Appreciate it. So I want to get into blood work a little bit and labs, because I think that's one of the areas that's really changed. Some of the keto doctors that I follow, docs are taught, like you said, that LDL should be low, HDL should be high. Total cholesterol should be below this threshold, and if not, you start looking at statins and prescribing medication. And so let's start with what is cholesterol, and why do we even care about it on a lab test?
Well, it depends on who you talk about cholesterol with. There are some people who look at cholesterol as another device or another way of getting energy out to your body. So that's what kind of a triglyceride is, extra fat being packaged up, sent out to your body. And cholesterol is another vehicle of getting that energy to the cells. But cholesterol is actually very important because your body actually makes it.
We make it, right?
So if we're putting less in, your body makes more. If we're doing something to slow it down, it's going to try to compensate. So that's part of it, is your body needs it. Okay, it's a key building block for most of your hormones, and hormones are chemicals released from one cell to go tell another cell what to do. It's a communication system. But like our sex hormones, our estrogen, progesterone, testosterone, cholesterol is a key building block. Cholesterol is a key factor in the function of your brain. So there's lots of all these different important things. And unfortunately, the drawback is sometimes we get, going back to what we were talking about, all these different systems, is when we get to a specialist, we sometimes look at it from one perspective. And we look at, we got to fix this. I'm not worried about how it's going to affect you the other way as long as we fix this one problem. Well, unfortunately, the systems and interacting with other systems, we've got to look at the bigger picture of that. And so cholesterol plays a role in that carrying fuel and building other components, but it's also a key component in the myelin sheath, or the tissue that protects the nerves, that helps nerves run a little bit more faster so it can jump from one gap to the next to get the information there faster. Well, if we don't have the myelin sheath, it takes longer for that information to get there, can affect brain function, neurological functions and stuff like that. So all these different functions can be affected by cholesterol.
Yeah, and I like what you said there, that you can't just look at it, with your blinders on and say, oh, your LDL is high, you need a statin, or your total cholesterol is high, you need a statin. So, there's a system that's going on, and if you look at those things, and I've noticed with my blood work, as I've lost the weight, especially when I'm eating more meat, like my LDL is actually higher, but my HDL is higher too, and my triglycerides have gone down.
Exactly.
So your HDL, talk about that a little bit. HDL to triglycerides.
So the HDL to triglycerides. So there's multiple ways of looking at cholesterol. The standard way is the old traditional way, where we look at the total, the LDL, the HDL, and the triglycerides. That's what we get. Now there is more, the lipoprotein, the NMR, that breaks the particle sizes. So that's where, if you hear about pattern A and pattern B and that type of stuff, so without going more in depth, because my insurances won't pay for the more in-depth studies, so a lot of people just want the traditional one. So it's digging more into it. That's where, if you take your triglycerides, the recommendation is less than 150, but the lower the better. And your HDL, again, depends on if you're male or female, it depends on where you should be, but basically the higher the better. So if we take the triglycerides divided by your HDL and it's less than 2, we consider it in a good range. But if it gets higher, then that could be more of that pattern B, or ones that we're more concerned about, having smaller, more dense, damaging LDL particles versus the big, fluffy LDL particles.
Is that the CRP test?
No,
CRP protein?
HSCRP is more of a non-specific. Again, it's a little bit more specific, and that's why the HS are more high sensitivity, or some of the tests will come out, say, cardiac. It's supposed to be more for the vessels, but studies haven't really shown that. It is more specific, but it's just a marker of inflammation. That inflammation can be anywhere in your body. Okay. But again, theoretically more in the vessels, or some would say even the visceral fat around the organs could be part of it. Having multiple joint pain, RA or rheumatoid arthritis or autoimmune type things can bump up that HSCRP.
So what is the test you can do to see if you have those, those small particles versus the big ones?
That would be a lipoprotein or an NMR, nuclear medicine or nuclear molecule type test of the cholesterol.
And you have to is that like an MRI type machine, or is it a blood test?
It's all blood test.
Blood test. Okay.
So again, some insurances will pay for it, some of them won't. And there's arguments back and forth on which one's better. Again, the newer ones give us more information, but if you can interpret it from the older, if you know what your kind of interpretation of the I wouldn't say algorithm, but kind of looking at it from a different perspective, gives you about the same information.
So if cholesterol is good in general, our bodies make it, and from kind of the analogy that I've heard is, that cholesterol helps repair cells as well.
Yes.
So it's kind of like the firefighters coming to the scene of the fire, and we're seeing more cholesterol on these blood tests, say like total cholesterol. Why do doctors even look at that number then?
Well, because going back to what we always were taught, that cholesterol causes the issue. And a lot of it goes back to after I'm trying to remember, World War II or the Korean War, where they were doing autopsies of some of these soldiers that were killed, and looking at their vessels, and they're starting to see plaques build up, and they go, oh, cholesterol must be causing the issue. And that's what the idea is, that's what's blocking the arteries, is the cholesterol. But going back to that analogy of firefighters, we always talk about, if you're driving into your neighborhood and you look over towards your house and you see smoke, and you're luckily when you get there, it's not your house, but your neighbor's house, and the firefighters are there. My question is, did the firefighters start the fire? And usually the answer is no. Well, how come? Because we're taught that firefighters aren't going to go in the middle of a neighborhood and start a fire. They're going to go out in the middle of Nevada, which they do have places out there, and start fires out there so they can control it.
The wildfires.
Exactly. But when we see it, we go, oh, this is causing the problem. Well, there's studies out there showing that they can show progression of it. And a lot of times, some of those studies are showing that the cholesterol is actually starting from the vessels around the arteries and kind of going inward, not from the inside the vessels, laying down and blocking it up that way.
Interesting.
So there's a lot of different theories and concerns about that.
Yeah, and a lot of the research that I've seen kind of points the finger to processed grains and vegetable oils, basically inflammation.
It's inflammation
causing these plaques. It has nothing really to do with the cholesterol.
Well, that's where the elevated insulin can exacerbate inflammation. Elevated sugars can elevate your insulin, therefore increase inflammation. Having those vegetable oils and how our body doesn't know how to use it in the cell lining causing inflammation. So that's where they kind of all add up, and it's taking years and years and years to get to that point. And the more we've had some of those components, the worse it's gotten.
Yeah, and I think that's part of the problem. Is it takes with metabolic disease and with inflammation, it takes several years before sometimes you even see some of the symptoms, right? And so it's easy with this COVID going on that this happens quick. It happens right away. But a lot of the studies I've seen about so-called healthy people, dying or getting affected by COVID, they actually have some form of a metabolic disease underlying. So,
and that's my takeaway is I think we're realizing that we're more metabolically sicker than we thought we were. Right. Oh, somebody's working out at the gym. They're quote unquote healthy. They look nice and fit, but they have a crappy diet. They're at higher risk of having that metabolic issues. Therefore, they got COVID. Or you hear of somebody, 43-year-old male dies of COVID. Well, we don't know the whole history.
Yeah. What's the comorbidities, right?
Exactly. What are the issues? What's going on? Mm-hmm. So that's the difficult part. We're blaming everything to this one particular virus, and it is more contagious. So I'm not blaming that. Yeah. And people are going to die from it. But I think there's some other underlying issues that we're not always looking at also.
Yeah, and my take on it is, if you really want to help yourself against this virus and any other one that comes along, right? Take care of your own body first. Take those steps, and that starts with what you're putting in your mouth and
trying to boost that immune system. And again, that's going back to cholesterol can play a role in that immune system, and trying to build it up and the exposure we get from different things, and trying to help us be metabolically healthier.
Yeah, one of the studies I found, it was actually kind of an inverse of what we're typically taught about cholesterol. That they found these centurions, these people that lived to 100 years old, actually had a lot higher cholesterol than those that died earlier. So I thought that was really fascinating.
And if you go look at some of the studies out there, a lot of women over the age of 65 actually live longer with higher cholesterol. So the question is, should I be putting them on it to prevent one problem, or is it causing some other problems? So again, that's the difficult part. And again, don't get me wrong, cholesterol medication is good in certain situations.
Sure, yeah.
So it's not like we're bashing that. It's the context. If you came and saw me and you just had a heart attack, yeah, you better be on a cholesterol medication because of some of the underlying issues and things we want to look at. But unfortunately, we're going, oh, we'll help prevent it. Well, it might makes other things worse. So again, don't want to just go on a particular medicine. Let's see what we can do to change or help with that metabolic health before, or at least have that discussion about the pros and cons of the variety of different medicines. So it's not just all or none type of a thing.
So that leads very nicely into the next question. So, we've got all these pharmaceutical medicines. it seems like, when we have a disease or have a problem and we go to our doctor, we want that quick fix. We want that with that pill or that shot or whatever it is. What role do you see the pharmaceutical companies having in, well, I guess our health in general? Let's start there.
In the sense of what?
In the sense of, are there situations where, like for statins, for example, where they're causing more harm than those that they're helping? So have you seen both sides of that?
Definitely.
I don't want to put you in. This is kind of a loaded question.
Yeah, kind of a loaded question, kind of tricky. Again, pharmaceutical companies are out there trying to solve problems, okay? And the difficult thing is some of the regulations they have to get into to get it FDA approved so they can actually put it to market so we can actually use it. And as we've known through multiple different things being taken off the market because maybe there were some issues we didn't understand. Again, going back to the whole complex aspect of the body is there's lots of systems affecting other systems. And when we're taking one pill, do we really understand how that pill affects it? It's improving the things we're looking at. It's showing the benefits, but how is it affecting everything? We don't know because a lot of times we're not looking for those other side effects.
Yeah, you see those commercials and they're like, well, this causes nausea, ED, insomnia, blah, 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 blah.
Exactly.
Blah.
So that's, again, they're not intentionally trying to hurt people. They're trying to solve a problem from one perspective. And again, even going back to the low-carb ketogenic-based diet, where a lot of pharmaceutical companies will see all these different pathways that are improving, trying to find a drug that can definitely help it, and they can figure out certain aspects, but they can't figure out something that's going to affect all these different aspects because they have to get approval through this particular pathway. So that's the difficult part, is they're looking through their regulations and stuff, how to help people. But the thing is, and I'm just out of joking, we always said, oh, make sure you're doing your diet and exercise, then let's do something. Well, let's delve into that diet and exercise first and see if that's going to help us. And if not, maybe these medications can definitely help us. And that's a very broad, non-specific thing about pharmaceutical, but they're trying to solve problems also.
Yeah, and I think one of the biggest revelations to me when it comes to type 2 diabetes was just you have to keep increasing that insulin amount if you're not changing anything else with diet, right? So let's go into that a little bit, and that was kind of what prompted that previous question, right? Because you've got this returning customer, this diabetic that needs more and more insulin, and some of these pharmaceutical companies, they're not. Well, let's go back to the insurance even. The insurance isn't going to cover sometimes, like at your clinic, weight loss, right? Yeah. They'll cover the insulin, that's fine, but they're not going to get to the root of the problem, which is oftentimes diet.
And that's why when people ask me how we're going to code it, and I'm trying to use everything for the insurance, I'm looking for the underlying issues. So you might have high blood pressure, but it could be correlated with your insulin. So a lot of times insulin resistance is the first thing I'm looking for. Plus you have the blood pressure. Oh, you might have high cholesterol. You might have family history of dementia. You might have family history of some type of cancer. Might have the family history of diabetes. Looking at all that, and by the way, you've got weight issues and you've got more higher visceral fat. And now we're going to delve into the diet and maybe some exercise and all these other aspects. So I'm looking for that, again, my one specific aspect that I look for is for insulin resistance as a code to kind of get that insurance to pay for it. Because if I say it's just for obesity, not very many insurance will do that, and they'll go, oh, we'll just go have surgery. Again, surgery can help in certain situations, and again, it has its role and it can help, but it doesn't always solve the problems. It can help it Band-Aid at first, and it can help a lot of people, don't get me wrong. But again, if you get back to that addictive aspect,
the lifestyle hasn't changed.
Lifestyle hasn't changed. You've got to work on the lifestyle aspect.
Yeah. And I lost my train of thought. We were talking about insulin. What are some success stories you've seen with type 2 diabetes, type 2 diabetics, putting them on a keto, low-carb diet and how that's affected their disease or their metabolic
I'm going to backtrack just a little
Okay.
bit. When people come to see me as a diabetic, I ask them, why do we always say diabetes type 2? When we're talking about diabetes in this situation, we're talking type 2, which is worsening of your insulin resistance to the point where your A1C, which is a test that looks at your average blood sugar, just to give you an idea, just for the numbers out there. Normal goes from 4.3 to 5.6. Anything from 5.7, so 5.6 puts an average blood sugar about 114. Anything from 5.7 to 6.4 puts us in the pre-diabetic range. That puts an average blood sugar about, if I remember, 134. I could be off on that one. Don't have that one memorized. But anything from 6.5 and above, you're considered a full-blown type 2 diabetic. Anything over 7 is now considered an uncontrolled diabetic. So keeping that in mind, when you get your A1C, if you remember those numbers, you can get an idea, oh, I'm fine, or I'm not, or I'm almost borderline diabetic type of a thing. But why do we say diabetes type 2 is a chronic progressive disease? Is none of the medications that we use are actually solving the problem.
They're just treating the symptoms. They're treating the symptoms.
Exactly.
Yeah.
So let's get back to the actual cause, or the actual, I look at it, we're the fuel of the whole thing, and that's where getting back to the diet with the sugar, things that break into sugar are going to bump up the glucose, or your blood sugar. Therefore, you're going to need more insulin, and over time, we need more and more insulin to actually do the job. So if your body can't compensate for it, therefore we now inject insulin and go higher, and they've actually now more concentrated insulin, so you're not just more insulin per unit, that we can give you more and more and more and more. So that's why trying to get people off the insulin, the body's still producing a lot of insulin. So when people go, my body's not producing it, unless you're a type 1, or a lot of times we'll call it a type 1.5, meaning they were a type 2, they become a lot more insulin resistance, and their insulin levels are now starting to trend down to where they were, and they can't compensate. That's where we have to use the insulin if we've already changed the diet and things aren't improving enough. So getting back to your question about some stories and people, thinking of one guy right now who is on 80 units of insulin, U500. So for every unit has 500 units of insulin. So he's taking 80 units of that twice a day. So it's a lot of insulin. In a short period of time, he hasn't lost a lot of weight yet, but he's taken his insulin level from 80 units down to 15 units, and he was taking short-acting in between that, and he's basically cut his insulin basically in fourth in about 6 weeks. But he's frustrated he hasn't lost weight, but he's on a lot less insulin, and has a little bit more energy, and he feels better, and his blood sugars are better controlled. So again, unfortunately, that's going back to what I do. Unfortunately, some people get frustrated because the number on the scale on the floor isn't improving, but we're now fixing the metabolic health. And we're not there yet, but we're making those journeys of trying to improve things, or getting people off cholesterol medications because things have improved, or blood pressure medications, and those types of issues.
Yeah, and I appreciate that message because, when we're focusing just on our weight or just on losing fat, I think we lose the big picture, right? Like you said, we didn't get fat in 2-3 weeks or even a month, right? It took usually years. And it's not going to be reversed in that same period. So.
Exactly.
So thanks for that message. That's great to, just look at how you're feeling, right? Mm-hmm. That was kind of the first thing that I noticed when I started cutting out the processed foods and the sugars and stuff and focusing on whole foods was I just felt better, right?
And that's always a good place to start with. If you're not sure where to go, or you're talking to your doctor, and again, doctors are out there to help us, so don't get me wrong. And I'm one of them, and I'm proud to be American. Proud to be American too. But to be a doctor. However, we don't get taught nutrition in medical school. Actually, it was kind of funny, just using a story. I have a nurse practitioner who works for me now, who was spending the day with me, kind of an interview, and I was seeing a brand new console, and I was talking about this, and I'm going, ask her, she has nothing, she's just here interviewing, ask her, how much nutrition do the nurse practitioner get in her program? And she goes, I got a handout. That's really? It.
One page?
The one-page handout. That's the nutrition we get. And again, I got more than most doctors because part of my undergrad was in nutrition. So I got to understand some of these things. But again, how we all respond. And unfortunately, a lot of doctors who have delved into this have had those problems and going, everything I'm teaching my parent or my patients aren't working. So I actually had to go do something, find something different to help me. When I fixed myself or started helping myself, I was like, wait a minute, this is pretty good. Maybe we can do something. Maybe I can incorporate it with my other patients. What can I do? Maybe I'll start with a few and try to help them. And that's what happened with me. I ended up in the ER in my last year of residency with chest pain. Everything worked out, but with having a family history of heart disease and obstructive sleep apnea and multiple joint replacements, they weren't diabetics at the time, but are now diabetics. It's like, I'm going that road. I don't want to go there. And I went back to my traditional, I've got to be hungry all the time, eat my food pyramid, salad all the time, and I was starving. Well, not starving, but I was hungry. I felt like I was starving. And I was trying to exercise and started running and doing stuff like that. And I saw some weight loss, but I didn't see a ton. But when I changed my diet a bit more aggressively to more of a low-carb ketogenic is when I started to feel better and function better overall. That's my story, but everybody has their own little story of figuring out what's best for them.
From some of the low-carb doctors that I follow, they kind of echoed your story, right? That they kind of got to this point where that they were obese themselves. They were following the standard of care that they kept giving to their patients. Count your calories, eat the food pyramid, your whole grains and all these kind of carbs is the base of the food pyramid, really. And really, I think it should be switched the other way around, right, with the natural fats. And they're realizing that this advice doesn't work, right? And so let's go into the ketogenic diet a little bit and how does that help reverse metabolic disease?
So the main aspect of ketogenic diet is basically getting your body into a ketosis. Or when people a lot of times will hear, when we hear diabetic and ketosis, you always think of diabetic ketoacidosis, which is usually occurring with a type 1. Again, like we talked about, type 1s do not produce insulin. So a lot of times what happens is your blood sugar goes up, but you can't get it into the cell. Therefore, the cells think they're basically starving, so they start breaking things down and putting more ketones or stored energy out into the bloodstream. Therefore, your blood sugars are high, your ketones are high. You feel like crap. You go to the ER and they check your blood, and those ketones are really high, and that can kill you. So, unfortunately, a lot of times when doctors hear about ketosis, that's what they think of. They don't think of nutritional ketosis, which we're keeping your insulin level lower. By doing that, allows this stored energy, that's what fat is basically an extra stored energy, to now come out into the bodies are called ketones. So when we're talking ketogenic-based diet, we're getting to the point where your body is now allowing us to use those ketones as part of your fuel source. And so when we get to that point, by keeping your insulin level lower and not having a lot of sugar, yes, you still have enough sugar for your body to function. There are certain cells of your body that do need sugar, but everything else can actually burn on those ketone bodies as an energy source. By keeping your insulin level low enough that we're now burning this, we get into ketosis. Now, a lot of times you brought up something about the whole sugar thing, and a lot of times they'll call it keto flu or Atkins flu. Also, basically, us going through withdrawals of carbohydrates is part of it. But another part of it is a lot of times we're losing too much salt, because one of the effects of an elevated insulin tells our kidneys to hang on to salt, water stays. But with a lower insulin, allows our kidneys to get rid of some salt. Therefore, we lose the water, so we need to replace more extra water and actually add some salt.
Add some electrolytes.
Exactly.
Okay, great. Yeah, and I remember when I first started this, the first book I read was Complete Guide to Fasting by Jason Fung, right? And it was just so simple but so revelatory, this process of ketosis. And I think this is something that everybody should be taught in elementary school, really.
I would argue that.
At least at some point.
I would argue they need to be taught. But in elementary school, I would recommend that I do think kids need to eat more often. So I don't want a lot of those kids to be fasting or going long periods of time. That's why I just wanted to make sure it's like elementary. Let's be careful, because growing kids are one issue, adults are a whole other issue.
Right. And what I was getting to was this thing that really struck me was, when you're not eating, your body will produce these ketones, and that's how you break your fat cells apart, right? That's what your fat cells are there for.
Exactly.
They're there for energy when you're not eating.
Exactly.
And when you are eating, then you're storing that energy, right? And you can't do both at the same time.
Exactly.
That was the one thing that I think
No,
everybody should know.
I agree. Yeah. I just don't want to go back to elementary school because we want them to eat.
Maybe
but again, because they're still growing.
Maybe,
Does that make sense?
Maybe
it's the last year of high school, type like that.
Yeah.
But again, part of us go back to why we're always taught to eat so often. Well, one, if you go back and look at history, it was actually considered a sin to eat more than a couple times a day. But it was more of the revolutionary, or the industrial revolution is when we started, well, we're going to have a long day, so we recommend before you go to work. We've now negotiated to give you a break halfway through work, and you can eat when you get home from work. Is that when you're hungry? No, but that's when we're allowing you to eat. And we were taught that we're supposed to eat 3 times a day. Some of us need to eat 3 times a day. Some of us don't. And the more storage we have, probably can get to the point where we don't need to eat as often. But again, there's multiple different factors. Some people like the idea, some people don't. So again, it's a good tool. But again, it's like everything else. We have to figure out what's going to work for that patient per se.
Right. And I think what really struck me was, when you're constantly eating, your blood sugar is going to be spiking, and then your insulin kicks in and it goes down and you go back up. So you got this like roller coaster thing going on, and your body doesn't know which fuel source to use, right? It's always burning the glucose.
Exactly.
So.
But unfortunately, the big noise out there was coming from the manufacturers, the food manufacturers. Well, they want you to buy more because that's how they make money. So that's where they emphasize the importance of breakfast and having your 3 meals a day. And after a while, they're going, okay, we've got 3 meals a day down, but we've got all these other times. Let's figure out something else we can get people. And that's when snacking came into play. Is in the past, you wouldn't go, oh, it's been 2 hours, let's eat.
Right.
Now, again, there are people out there who do need to eat every 2 hours. Somebody who's working out.
Probably a small percentage.
Well, small percentage, but if you're doing high-level athlete,
sure.
You might. Again, if they're doing high-level, they might need to. A lot of times, if they have a lot of storage, they probably don't. That stored energy. But if they're using a lot of energy on a regular basis, they might need to. But most of us don't. Well, most of us aren't spending all day in the gym, burning all that energy on a regular basis.
Not doing that Michael Phelps workout, 6,000, 8,000 calories, where we need just to maintain baseline.
Exactly.
Yeah. Let's go back to the A1C.
Yes.
So A1C is pretty common to get ordered on your blood work, right?
Kind of a standard one to look at, especially if you're concerned about family history, diabetes, or whatever.
So why, when I've gotten into this research, that insulin seems to be a better marker. Why isn't that common like A1C?
Couple reasons. One is we were always taught that diabetes. Let's go back a little bit. Let's go back into the 1920s when the discovery of insulin. We now figured out what insulin was. They go, oh, all diabetics need to have insulin. Well, we didn't understand that type 1 and type 2 were a little bit different. So we tried to treat it the exact same way. I was like, these people need insulin. It was down the road we actually realized that type 2 actually were producing a lot of insulin. But we were taught that it's all about your blood sugar level. So that's where the A1C. Let's check your we would check your blood sugar every once in a while, what was in your urine. Then we got fancy enough, we can check it in your blood. Now we got the big fancy test. We can see what your average blood sugar, so you don't have to poke your fingers often, see what it is average over the last 3 months on average. So we're focused about how the sugar is. We were never taught to look at the hormones that actually help regulate it.
So
and that's
back to this concept of looking at the source rather than kind of the symptoms.
Exactly. But again, they're looking at it, and there's not a lot of medicines out there to help lower your insulin. There's ways to raise it, but not to really lower it. But we can do these things to lower the blood sugar level. So we got so wrapped up in that aspect, and it was all about the blood sugar. And again, when we go with diabetes, where's your A1C? That gives us an idea of how well it's controlled or what we need to do. It's trending out. You must be doing really good. Well, I'm injecting more insulin. I'm gaining weight. Well, but your A1C is going the right direction.
Yeah.
So again, going back to that specialist, we get so wrapped up in one perspective, not looking at the big picture.
So what can insulin number, fasting insulin, tell us about differently than your A1C?
Well, your A1C, like we talked about, is your average blood sugar. The insulin is how much insulin your body is producing to help control that. And it depends on the lab values, can go from anywhere from about 2.6 up to, one of the standard labs is up to 25. Some of them will say it even up to 45. So there's a wide range. And again, unfortunately, with any of these labs, there's what the lab considers normal because of the tests they've looked at, and a certain number of percentage have to fit into that. Well, you have to kind of delve into a little bit more, and that's where Dr. Kraft, a pathologist back in Chicago, did all these different studies looking at the amount of insulin and the sugars, and they have what they call the Kraft protocol, or different ways of looking at the amount of insulin. By using those ideas, I try to get your insulin level lower. I like to have it less than 5, acceptable up to 10, and if you're a teenager, I say up to 10, maybe 15, but the labs will say up to 25 is considered normal. In my opinion, you're producing a lot more insulin to control, especially if you have all the other risk factors or other underlying issues.
Yeah, and it seems to be that some of these blood markers have changed over the years, right? That as we've gotten more sick, more metabolically unhealthy, that, even the cholesterol, right? The cholesterol numbers have gone down. Like the threshold used to be, I don't know what it was, 250 or something, and then it came down to like 200
remember
or
250,
something.
260, and then they've brought those down. We want to lower and lower and lower. Well, the idea is if we get lower, we're going to have better health. Well, unfortunately, not just fixing one number is going to help the underlying problem.
Yeah, and I think it's kind of the same thing with the insulin, right? That we see more metabolically unhealthy people, that the average kind of pushes that number over farther than it used to be, right?
Exactly.
Like you said, you like to see less than 10 or around 5.
Yeah.
Where since 88% or 70 to 80% of people in America are metabolically unhealthy, that range has kind of extended, I think.
Yeah. So again, that's the difficult part, and the labs are trying to just keep their numbers where they're catching a certain percentage, not catching them all.
Right. So what does that tell, the lower the insulin, does that correlate directly to how insulin, sensitive, insulin resistant you are?
Theoretically, yes, but not 100%. I can think of a patient I actually saw today that her A1C was great, but her insulin level was good, but she has a strong family history of diabetes and cancer, and she gained a lot of weight in pregnancy, and again, it's another thing to look at, and gave birth to large babies. So she has multiple risk factors of insulin resistance, even though her insulin level at the time was good. So again, I still recommend that low carb. Again, in that situation, I might go, okay, maybe we can go more low carb versus keto. If she had a lot higher insulin, I would go, maybe we need to push more for the keto or more aggressive in keeping the carbs a lot lower than where she's at.
So explain that a little bit. What's the difference between a low-carb diet and a ketogenic diet?
Low carb, some of people would argue what level you're cutting out. Unfortunately, the standard American diet is usually well over 200 grams of carbohydrate. Yeah. Exactly, high carb. And again, not all carbs are the same. So again, we try to make it simple, saying, cut out carbs. Well, getting it from vegetables and maybe fruits and seeds are probably a lot better, and some people can tolerate it, some of us can't. But and again, sometimes just very general statement of sometimes women get away with a little bit more carbs than men. So it depends on their carb flexibility. But anything less than 100 is considered a low carb based diet. Okay, it's kind of the standard acceptable. Some would argue it's this.
100 grams
100 grams per day of carbohydrates is probably considered a low carb. And to go to ketogenic, some would argue it's less than 50. Some would say it's less than 20. Again, it's more of your sensitivity to it. But again, it's like cutting it in half, if not going even lower.
So it's kind of on a scale.
Exactly.
Of, how much sugar do you want to...
But again, that's looking at the carbs we're cutting down.
Right.
But again, theoretically, the more physically active you are and the more insulin sensitive you are, you might get into ketosis with having your carbs at 80. Depends on where you are. So again, that's where that individual aspect comes in. So we can't go, everybody has to be here. It's more, these are guidelines. Let's see how you do. You don't feel good here, female. Let's go up. But they check your ketone levels, and they're still in ketosis, and they're at a higher level of carbohydrates. Well, great. Count your blessings because you can get away with it. Some of us can't. Some of us have to go more of a carnivore and basically cut out all carbohydrates per se because of other underlying issues.
So why have carbohydrates gotten kind of a bad rep recently with this ketogenic low-carb diets? What is it within the carbohydrates, or what is a carbohydrate? How does it affect our blood sugar?
And again, going back to what we talked about, or at least we brought up the whole macronutrients, it's we're focusing on one aspect, but not all carbohydrates the same. If it's coming from green leafy vegetables, or a good rule of thumb, at least I always tell my patients, if it's a vegetable that grows above the ground, it's a lot better than a vegetable below the ground, just because there's a lot more carbs. If you're going to have more carbs, maybe you're going to the fruit in season that you can grow around here. All of those break into some sugar, but having the natural fiber with it definitely has component. And people go, but what about micronutrients and what about vitamins? Well, nobody ever talks about the vitamins and the micronutrients that come in meat or some of the like bone broth or organ meats,
yeah.
or
liver,
things like those.
You know, liver has the most nutrient dense food on the planet.
Exactly.
Heard, yeah.
Or eating a whole animal. So eating that nose to tail, or eating a whole egg. Basically, it's everything it needs to create an animal. Eating small fish, sardines,
Ones with the bones in 'em,
anchovies.
right?
Exactly.
Yeah.
You're eating everything. So eating that whole organ or that whole organism is going to give a variety of different components. So yes, liver has a lot. Some of us going, I can't stand liver. Never learned how to do it. But I also lived in Korea where they'll eat the whole pig. I still remember going through markets and they'd have the head that's been roasted and stuff like that, and that's what they'd eat. Or they would eat different sea urchins and stuff like that. You'd eat the whole animal. So you're getting a variety of those different organisms and nutrients from the different parts of those organisms.
So what is the first thing when someone comes into your clinic? I know you talked about individual, but kind of a general baseline. Do you tell them, cut out the soda, cut out the processed sugar, or what is kind of the first step you do with their diet?
Depends on how bad it is, but a lot of times the basic, I go, when you're truly hungry. So start with that. If you're not hungry, don't eat. And if you feel like you have to eat 3-4 times a day and you're truly hungry, great, eat. But when you do eat, you pull out the plate. I don't want the smallest plate. I don't want the platter. I want the standard plate. First thing is prioritize protein. Put the amount of protein you think you need or you would normally get. Now, don't fear the fat. So maybe you're grabbing a fattier cut of that meat or adding a little bit more fat to it, type of thing, or adding some olive oil. Not a ton, but just butter, a little bit.
Yeah.
Butter, maybe bacon grease, whatever. Just add a little bit more fat to it. Then on your plate, put the carbohydrates. Start with the vegetables. And if you get more than that, maybe the starchier vegetables. And if you want more than that, then you put the fruit. And if you're going to have processed stuff, put that on your plate. Now, before you eat, take half those refined carbs out. Just cut it out. Get rid of it.
All the stuff that comes like in a box.
Exactly.
Right?
It comes in a box. Anything you know is going to break into sugar, anything goes, ooh, I can't wait to have that, maybe get rid of it. Does that make sense? Eat what's on the plate. Take your time. Yes, you can put your fork down, all that kind of stuff, but take your time. If you finish that plate and you're still hungry, give yourself 5 to 10 minutes, maybe 15. Yeah. Go for a walk, but have a conversation with whoever is there. Get up and walk around. Do something else. Read a book, whatever. Give it 5 to 10 minutes. Set an alarm. If it goes off and you're still truly hungry, go back, repeat the process, but start with a lower amount of protein.
Yeah, I like that. And, in today's society, we've got so much going on with kids going to activities and work and everything, right? So we're trying to scarf down as much food as we can in the shortest time. And I think that's part of the problem that's led to this, this obesity epidemic, is that we're eating before we get those satiety signals sent to us.
So jokingly, when you look out some of my the clinic rooms, it looks at a fast food. And jokingly, I'll tell the patient, going, and because of the whole COVID and stuff like that, they're not letting people in, or they're starting to do a little bit more, but all the people trafficking through the drive-thru, and I'm joking, going, they grab their food, and by the time they wrap around it and get on the main road, they probably had that food all devoured. It's gone. And they're almost like, I didn't hardly taste it. I'm still hungry. And now 5, 10, 20 minutes down the road, they feel like, holy cow, I went way overboard and I can't reverse it. So that's where taking the time, being more mindful about your eating. So the types of foods, but when am I hungry? taking your time to allow the gut hormones from our gut and our adipose tissue or fatty tissue to tell our brain we're done.
How long is that usually?
Everybody's different, but it does take a little bit of time by taking the time. So 5, 10, 20 minutes, but again, depends on where your insulin level, especially the leptin, you might have to be making more and more and more before you get the signal through. So that's where I always say the idea of look for the signal to stop. Because when you get that signal, not that you have to stop mid-fork or midway up and drop it. No, finish that bite, but be done.
Take your time.
If it wasn't good enough to eat in the first place, obviously don't keep it. But if it was good enough, there's two great inventions. It's called the refrigerator and the microwave. You can put it in the refrigerator and warm it up later.
Right. Yeah, I love that message, and it ties right into one of the interviews that I did with a couple of people that practice Buddhism, and they both went to this Buddhist retreat. And the monks there, they were telling me about how they ate, right? And they eat in silence, right? They're not like conversing. They're focused on their food. They're thinking about where this food came from, the sunlight, the rain that's produced this vegetable, or the animal that's given its life for them, right?
Exactly.
And they're chewing their bites like, sometimes up to 30 times. So they're really mindfully eating and doing this slow thing that you said. And I don't think I'm going to be to that point, but I can definitely do, what you recommended. That's like finish the plate, go for a walk, talk for 5-10 minutes, come back. If you're still hungry, eat some more of the whole foods, and then repeat.
Exactly. And having a wide variety of different vegetables, if that's for you, is a good option. There are other nutrients, but it doesn't feel like you have to just eat that. That's where having that variety of, again, the fattier meat is just more fuel source. The fat's a good fuel source.
Yeah, let's tie into that. So Adrian and I are doing this carnivore month. So we're doing a 30-day carnivore diet, and we've found this book, Carnivore Cookbook by Jessica Haggard, and we're going through the recipes here because we didn't want to just do, like hamburgers and steaks every day.
Again, you could if you want, but having that different organ meats and eating the same thing over and over and over can cause what we call palate fatigue. It's almost like, I just can't eat eggs anymore. I can't have that anymore because I'm just so sick and tired of it. Again, there are some benefits to that because you get sick and tired of a certain thing. So maybe you'll wait till you're actually truly hungry enough to actually eat.
Yeah, and I, as much as I love burgers and steaks, I get a little tired of them too, right?
You definitely do.
I incorporate, some lamb in there, and we've been making some organ meat. So we did some liver and some beef pate and things like that. So it's been fun. So let's talk a little bit about carnivore diet, or at least, what I like to call it is hypercarnivore.
Okay.
There's actually a book called Hypercarnivore by Don Matez, and he used to be kind of a vegan vegetarian chef who kind of migrated toward the other end, and there's a bunch of science that goes along with how he, cured a lot of his autoimmune, I believe, some of his problems. But why do you think that this, it goes back to the ancestral diet, right? That my grandfather, my grandmother, and our ancestors, that's what they eat. They raised livestock, they butchered them, and they ate them. So why do you think that animal products and red meat in particular has been vilified over the last, 20, 30 years?
Lots of different things. If you go look up, I'm going to probably slaughter his name. It's Dr. Gary Vetke, who's an orthopedic surgeon out of Tasmania, if I remember right, has done a lot of research on, because they were trying to take away his medical license.
Yes, I remember that. I think he's in New Zealand.
New Zealand, Tasmania, something like that. But he and his wife went and did a lot of the research and stuff like that. And again, nothing against any groups and stuff like that, but there are some religious groups that are more the vegetarian aspect. And they became very prominent in a lot of different groups and kind of really pushed that idea with the idea of vegetarian as a holistic aspect. And I'm a religious person, so I'm not saying anything against anybody other because that's important to them. However, they almost kind of started pushing almost like this is the only way you can heal certain things. Well, if you go scientifically look at that, the vegetarian-based diet is very deficient. You actually have to add supplements. unless you're
It's hard
adding
to do,
B12.
It's hard to do without supplements.
Exactly.
I think,
You have to do that. So again, some people do better and they feel better with that. So great if that works for them. And again, even my patients who want to try it, I'm going, let's try it. There are some benefits because we're getting away from the standard American diet and all the processed
food.
Exactly.
Right?
So that's where they're getting the benefits. But a lot of times with the supplements or having to get some of that stuff, by getting away from that, that's where incorporating the meats can definitely help with some of that. But again, it was more of that whole holistic mindset, more of a theory behind it than the science proving that it actually worked. And a lot of times that people just went with, I feel better, I'm doing better than I was, which is a step in the right direction. And again, that's kind of my mindset of sometimes about the Mediterranean also, is it's a step in the right direction, but maybe not enough of a step.
Yeah, and the viewers might be shocked to hear this since we're doing a carnivore month. But there was a time in my life where I was a vegan, I guess, because I still ate eggs and dairy. But I focused on animal product, or not animal products. I didn't eat animal products except eggs and dairy. And, I went vegetarian and I was feeling great. And I did that for, I think, about 6 months. Yeah. And I kind of drove my wife crazy because she wanted to
Where's my meat?
She's like, where's my meat? But, I had a lot of garbanzo beans and a lot of the proteins and stuff like that. But then, I think the key is just to listen to your body.
Yeah.
And, I kind of started craving those meats again. And there's a lot of, we're not going to go into it now, but there's a lot of political things about veganism, and there's a lot of money being spent into these pea proteins and these Impossible burgers and all this stuff that's got, you look at the ingredient list and you're like, what the heck is in this? I could just eat a hamburger and it's meat, right?
Exactly.
And it's not like...
So again, it is more of that, but also part of it you need to look at when they go, this has got so much protein. Well, what's the bioavailability, or how can our body get it? That's the problem. When it comes from animal or from plant products, there's not as much available to our body to absorb. And again, there's no pure, they'll argue soy has everything outside of that. But again, too much soy can actually cause estrogen issues in some men. So keep that in mind. But again, some do well, so don't get me wrong. But again, adding more meat can definitely help. And our body, then again, not a big evolutionary, but some would argue that the human race kind of evolved because we ate meat, because our guts designed different than the carnivore animals we know out there who have longer guts, multiple guts to help break things down so we can get the nutrients from it. We don't. We have a shorter gut with a high needing organism called our brain that actually helped us progress, and that's where having higher energy levels or more fat can actually help with the brain function.
Yeah, I've heard that same thing, that humans crave more fat because of the energy that your brain is.
Well, for the brain to function, but also to help with all the myelin sheath to protect the nerves. Again, most of it's coming from the fat, so you definitely need it.
Yeah, and I've got to promote this book here. So Paul Saladino, he is an MD that really promotes the carnivore diet. And so if you're interested in reading about how the science of the carnivore and how, meat really, as he says it, is the optimal fuel, and plants and grains are kind of the survival fuel, this is a great book to kind of dive into the science.
Haven't read it. It's on my Amazon wish list. So
great. Yeah.
I have a lot of books there.
Yeah, I hear you. There's too much going on, right? There's too many books out.
Yes.
Well, we've talked about a lot of different things. Insulin resistance, reversing diabetes through diet. Before we leave, talk a little bit about type 1. We haven't talked about type 1 too much.
Okay.
But how can a low-carb ketogenic diet help with a type 1 patient?
So again, with type 1, you have to give yourself insulin. And insulin is essential for life. So we're going to have to give it. But we're not putting as many sugars or glucose or carbohydrates into the system. Therefore, you don't need as much insulin to get into the cells. So a lot of times we're going, you have to count your carb count, so therefore you have to do so much insulin. Well, if we back off on the amount of carbs that we're putting in, you don't need as much insulin. So again, insulin, if your body produces or coming from the pen, still can cause weight gain. In fact, I've got friends who are type 1s who have been gaining weight, and jokingly I'm going, well, I'm willing to talk to you. The reason they're not going to is they're actually a medical provider too, and they go, they go, I hear you, but again, going back to the whole carbohydrate, that's why going carnivore or doing some of the ketogenic or even low carb, the benefit is carbohydrates in general are not essential because our human body has a process called gluconeogenesis that can actually break protein into sugar. So that's where we're saying your body needs sugar, but there are no carbohydrates that are essential to actually do that. And again, depends on how body's functionality, but our liver can actually make as much sugar as our body actually needs to function.
Yeah, and I've heard that, you only really have like a teaspoon of sugar floating around your bloodstream.
Maybe between 1 to 2.
So it's like that's just mind-blowing to me,
Exactly.
that the amount of sugar that we're putting into the standard American diet. So.
Yeah, so going back to how it can help improve it, again, you're not going to totally reverse it, but again, even with type 1s, you can develop insulin resistance. So the cells don't respond to the insulin that we're actually injecting. Therefore, they can start gaining weight because we have to give them more insulin. So unfortunately, I always say there's only one type of insulin, or you only have one. You can have insulin type 1 or type 2. Actually, you can have what we call double insulin, so you have type 1 and type 2.
Okay, well, I don't want to dive into that.
Too much information, probably.
That sounds like another hour. But it's been fun talking with you. I want to leave you with one last question, and then you can tell folks where they can find you. So my question is, we talked about medical training and how few doctors, how little they've received nutritional training.
Yeah.
And I feel like, I'm not trying to boast, but I feel like I've read, 24 books last year on nutrition and ketogenic diet and fasting and all this stuff. So I feel like I'm a lot more knowledgeable than the standard American doctor as far as nutrition, and I listen to a lot of podcasts and things. How can someone like me that had kind of these alternate views, and it's been great talking with you, to actually find a doctor that understands.
So come see me. How's that?
Come see you. But besides finding a great doc like you that's using low carb and ketogenic diet to cure patients, how can someone like me talk to a doctor without sounding boasting or like I know better than you?
Yeah. And it kind of depends on your relationship with your doctor. So if you really know the doctor, have that honest discussion going, okay, I want to do an experiment. I'm the one that's going to pay the consequences. Can we do this? Let's try 3-6 months. Let's do blood work now. Let's say cholesterol is the issue. And you're going, I'd rather stay off the medicine. Let me change some diet. I want to try this. From the research I've looked at, I think I'm going to be safe. I'll check in with you. Maybe I'll phone you if I have any problems. Maybe I'll see you in 3 months, but let's plan on doing blood work in 6 months. Let's order it now. Give me the order. Let me do this experiment on me because I'm the one that's paying the consequences. I'm not blaming you because I'm the one that's doing it. And see how I respond. If you do that and the doctor goes, no. Again, where's your relationship with your doctor? If it's the first time you met a doctor, that you got to build that rapport, or hate to say it, but go find another doctor who's willing to at least work with you.
That too. Like there's other doctors, right?
There's multiple doctors. Again, we all have our own specialty, or we're better at one thing or another. But in this world, a lot of people will talk about Dr. Eric Westman, who actually, one of the few doctors actually worked with Dr. Atkins back in New York. Dr. Westman's out of Duke University, but that's what got him. He goes, I'm into research. I had a patient who had lost, I don't remember the amount of weight, so let's say 30 pounds. And Dr. Westman goes, but what about your cholesterol? And the patient goes, let's do a test. You have my old ones. Let's do it now and see if there's any improvement or worsening. And he saw the improvement and it goes, that's not right. That's not what I've been taught. And that's what kind of got him going there. So have that discussion with your doctor going, the only person that's going to get hurt is me. It's not on your license. I agree that I'm not going to sue you because you told me to do something. And unfortunately, a lot of times we get scared that, well, if something happens to the patient, they're going to come back because it's my
liability,
fault.
Right?
Liability.
You're not following
exactly.
the standard of
We're
care.
not doing standard of care. So as that patient, don't bring a whole big books or reports or things going, this is what I want to do. It's like, okay, I want to do an experiment on me. Can you be my advocate? Let's order the test. Let's see what happens. Things got worse. Okay, let's have a discussion. What are my options? What do I need to do? Or it got better. Okay, maybe, it was 6 months. Can we do it? Can we do a year? And have that discussion. But let's make an agreement on what we're going to do and work together on my health to help me. Because that's what most of us doctors who have gotten into it, we saw the changes that we did to ourselves, and we're going, if it works for me, maybe it'll work for you. And learn the different things. So having that discussion with your patient, or with your doctor, is like, I'd like to try an experiment on me. The only person that's going to get hurt is me. If things get worse, I'm willing to at least discuss different options, but I want to try to avoid medicine. Unfortunately, a lot of times doctors feel like we're here to solve the problem. So you come in and see me, your blood pressure's high, here's a medicine, because I've got to solve it. It could have been going on for 10 years, and you're with me right now. I've never seen you before. We got to do something now. Well, it might be only times that you have high blood pressure is when you're in the doctor's office. So maybe that's the whole white coat syndrome. But look at different ways and have that discussion. It's like, can we try some different options? When do we decide to come back and readdress it? Let's have a plan. Let's make an experiment on me. Or let's do a couple of people and go from there. So have that open discussion, but part of it is building that rapport. And unfortunately, our society is I only show up when I get a cough, cold, I hurt myself, and then have that discussion. It's hard to have that discussion with your doctor when you don't really know him or her type of a thing.
Yeah, I appreciate that. That's good advice. Just, go and say you're going to experiment on yourself. You don't want to try the medicine. You want to try your diet, or there's some other things first. That's what Adrian and I have been doing. We've been kind of experimenting on ourselves, right? Not necessarily going to our doctor and telling us, because we don't have any issues, I don't think. But yeah, just
we don't know.
I don't know. Maybe I do. But yeah, having that rapport, I think, is great, because you can fire your doctor is the point I want to get across, right? You don't have to use the doctor that's closest to you, right? There's other doctors out there. You find a doctor that you can build a relationship with and that has the personality type that you get along with.
And again, if you have some of these problems, especially right now, to my understanding with the COVID thing, so keep in mind we're still in that, with the telehealth, the insurances are paying for it. You're not limited by the state line. So technically people I already get people from Wyoming, but people from California or Illinois or whatever who hear about me, technically right now I can establish care doing that telemedicine. Now down the road, we don't know how long it's going to last. They might come back and say, no, it has to be in certain ranges and stuff like that. But right now they're paying for it. But even if you don't, if it's that important, a lot of doctors are at least doing some telemedicine. You might have to pay out of pocket, so keep that in mind. But looking for different options that can actually do it. And if you're looking for somebody just from the weight loss aspect, one website, if you don't want to come see me, so I still like to see you, but if it's not me, a couple of websites would be OMA, or Obesity Medicine Association. It has a list of doctors. Diet Doctor has a list of some low-carb based diet. You can go to American Board or ABOM.com. We'll give you a list of, or maybe org. You have to org, but look up some different providers that, or at least from an obesity aspect, look for providers. We all do it a little bit different, but again, you can look at those different things. There was a list out there for low-carb doctors that some other podcasters had out there. So if you do a little search on the internet, you can probably find a list of people who are at least willing to have that discussion with you. And then keep in mind, insurance, cash pay, however. But with technology, we can help a lot more people.
Yeah, it's a great time to be alive. We can find a doctor, almost anywhere and connect with them. So yeah. I like it. Well, it's been great talking with you and gained a lot of wisdom, I think, today. And it's been fun finding a doctor that's, been trained. Who's willing to talk to about it.
Yeah,
at least understands these things that I'm bringing up, and who's had more of the nutrition background and is looking more at the whole picture instead of, let's just pump insulin, let's look at the diet. And
again,
lifestyle.
Insulin's a very essential thing. If we need it, we need it. But maybe we've changed the diet. Maybe we don't need it as much, or some of these other medicines.
Right. Okay, Dr. Rigby.
Yes.
Your camera's right there.
Okay.
Tell our viewers where they can find you, and maybe one last piece of advice or wisdom.
Okay. So my website is utahmedicalweightloss.com, or you can also find me at Ogden Clinic. I don't know if you can see my shirt, but ogdenclinic.com. On Instagram, at Ogden Clinic Medical Weight Loss. Let's see. Facebook is, again, Ogden Clinic Medical Weight Loss. I'm also part of a small group online type of education. It's called Why Weight. It's a Facebook group to kind of help people who are looking for information to help with this. We have a dietitian who does more ketogenic, one of my nurse practitioners who does a lot of this also. So we're putting together, trying to get people more information out there. So I'm here to help. My biggest thing is we're here to help you. We got to look at the metabolic health. We want to help improve your health. Again, weight loss is important, but fixing your metabolic health is more important.
Awesome. All right, viewers, until next time, hit that subscribe button so you don't miss the next episode, and follow us on our carnivore diet journey. We've been having a lot of fun there, and it's a little more action-oriented than just sitting here talking. As much as I enjoy listening to our guests, it's fun getting up and going to the oven and stove. So
Exactly.
We'll see you next time. Thanks again, Dr. Rigby.
Well, thank you.